Good morning, good afternoon. Welcome to today's presentation, Canada's Refugee Health System Atlas, National Innovation with Global Impact. Before we begin our presentation today, we would like to begin with an acknowledgement that N4 is hosted at CHEO, which is located in Ottawa, Ontario. Ottawa is built on unceded Algonquin and Anishinaabe territory. The peoples of the Algonquin and Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. We also honor all First Nations, Inuit, and Métis peoples and their valuable past and present contributions to this land. My name is Colleen Drake. I am N4's Project Engagement Coordinator, and I will be moderating today's presentation. My colleague and co-host, Andrew Tomeyer, Education Coordinator, will be monitoring the Q&A box today. I am now pleased to introduce you to today's presenters, and I'm going to ask that you turn on your video as I introduce you. Dr. Annalee Coakley received her medical degree from Queen's University in 2001 and completed her residency in 2003 in the university's Department of Family Medicine. In 2008, she relocated to Calgary and began practicing as a family physician at the Mosaic Refugee Health Clinic, where in 2012 she became the medical director. Dr. Coakley is a passionate advocate for programs that are crucial to her patients' health and well-being. She was part of the team of concerned citizens who spoke out about cuts to the interim federal health program and spent countless hours working directly with patients who had been declined status or lost their healthcare privileges. Since the reversal to refugee health cuts, Dr. Coakley and her team at the Mosaic Refugee Health Clinic have served newly arrived refugees to meet their health needs, from chronic diseases to mental health concerns. She is the co-director of Refugee Health YYC, co-chair for the advisory board of the National Newcomer Navigation Network, and co-chair of the North American Refugee Health Conference. She has received the AMAS's Compassionate Physician Award and Queen's Platinum Jubilee Award. Dr. Gabriel Fabreau is an assistant professor in medicine and community health sciences at the University of Calgary. He co-directs Refugee Health YYC and O'Brien Institute for Public Health Research, Education, and Innovation program focused on the health and healthcare of refugees and asylum seekers in Canada. Clinically, he provides patient care at the Peter Lougheed Centre for newly arrived refugees at the Mosaic Refugee Health Clinic. Dr. Fabreau trained in international medicine in Calgary, completed a fellowship in general international medicine at Harvard Medical School, and holds a Master's of Public Health from the Harvard T.H. Chan School of Public Health. His research emphasizes health services and public health for refugees and socially vulnerable populations. Welcome, Annalee and Gabe. I just have a few housekeeping slides to take care of. Today's session is being recorded and will be uploaded to our N4 platform. We will share this with you as soon as it becomes available. Should there be technical issues during this presentation, we will inform you with the details for an alternate makeup session. Before we begin today's event, I would like to take a few moments to introduce you to the platform features to help enhance your participation experience. Throughout today's session, we invite you to write your questions in the Q&A window. We know that sometimes many of you might have the same question or be interested in particular response. Today, you have the option of upvoting a question. Please upvote your questions you are interested in hearing the answer to, and we will prioritize these questions for our speakers. With that said, let's jump right into today's presentation, and I will pass the virtual podium over to Gabe. Thank you so much.
Perfect. Thanks very much to everyone for attending and the opportunity to present. 4 years of COVID, and I hope we have webinar and Zoom presentations down pat. Can someone tell me if you're seeing the intro
We're
slide?
seeing the presentation, Gabe. Success.
It looks great. It looks great. Thank you, Gabe. So welcome, everyone. Thank you so much for being with us today. We're very excited to share with you our first iteration of Canada's Refugee Healthcare System Atlas. It's a national innovation. Many of you participated across Canada in its development. And we're hoping that in future it has a global impact. And what we're looking for today is we would really appreciate your engagement and your feedback so that we can make it more useful for you and others. Next slide. So we have no disclosures. Our research funding is from CCRHS, the O'Brien Institute of Public Health, and the Alberta Children's Hospital Research Institute. And like N4, I would also like to acknowledge, especially because refugees are Indigenous people, similar to refugees, have been forcibly displaced from their land, from their communities, and from their families. And the University of Calgary, which is where Gabe and I are located, in the heart of Southern Alberta, we'd like to acknowledge and pay tribute to the traditional territories of Treaty 7, which include the Blackfoot Confederacy, which is comprised of the Siksika, the Piikani, and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki, Bearspaw, and Goodstoney First Nations. And the city of Calgary is also home to the Métis Nation of Alberta, Districts 5 and 6. Next slide. And so today we'll just very quickly review recent immigration levels to Canada, the refugee healthcare gaps, our refugee healthcare system or systems, since it's a provincial jurisdiction, the Canadian Refugee Healthcare Atlas, and then we'd like to open the floor for your feedback and suggestions. Next slide. And as many of you know, when you're in the business of serving refugees, it's a growth industry. So across the globe, there's over 110 million forcibly displaced people, over 36 million refugees, many of whom are from 3 countries. So namely Syria, Afghanistan, and the Ukraine. Next slide. And if you look at the map across the world, you can see refugees are being produced or made everywhere, but especially in the Middle East and Ukraine right now. Next slide. Although despite the numbers, so there are very high numbers, but very, very few are ever permanently resettled to a safe third country. And so out of the 1.5 million people that the UNHCR estimates is in need of permanent resettlement, only 7% are ever offered permanent resettlement in a safe third country. Next slide. Although having said that, Canada is a global leader. And so we resettle more refugees than any other country in the world. And so this is something that Canada really ought to be proud of. And this is why we're viewed as a global leader in refugee resettlement. Next slide. And, you know, I've been serving refugees since 2009. And what I've recognized over the past 14 years is crisis seems to be the status quo. Every time we encounter a new crisis, whether it was the cuts to interim federal health, the Syrian refugee resettlement, Yazidi resettlement, the most recent Afghan resettlement, every time I think, oh, we'll push through this crisis and then we'll return to some sort of baseline. That's actually sort of in my imagination. We never actually return to any baseline. We just simply go from crisis to crisis. And so it just highlights the need for us to be able to meet the needs of newcomers and be very flexible in our healthcare response. And if you look at the most recent years, so in particular in 2022, between convention refugees, asylum seekers, and the Ukrainian evacuees, we've welcomed 375,000 vulnerable newcomers to Canada. So that's quite the accomplishment. Next slide. And as the WHO has recognized, and I think all of us recognize in our day-to-day work, migration is a key social determinant of health, and refugees and migrants remain amongst the most vulnerable and neglected members of many societies. Next slide. And so in Canada, where we face a challenge is that resettlement is a federal jurisdiction, whereas healthcare is a provincial jurisdiction. And the lack of coordination between these sectors has led to a very strained healthcare system, and in particular, strained healthcare system which responds to the needs of refugees and other vulnerable newcomers. And across the past 14 years, in each refugee receiving jurisdiction, refugee clinics have been developed by people, service providers on the ground who've recognized that there's a gap and there's a need to produce culturally competent and safe care for newly arrived refugees. Next slide. And so this is why we've developed, and we did this study trying to characterize Canada's refugee healthcare system. And I'll hand it over to Gabe to explain the research that's been conducted since 2016.
Very good, thank you. Annalee and I have been partners for over 10 years, and what she meant to say is, take it away, nerd. It's time for the nerdy stuff. So thanks, Lee. We did launch this study, and we did it with the help of everyone in the country. And so really the protagonists, we're really excited today. We're going to launch our third version of the Atlas, which was always the goal of this study, CIHR funded study that we started. Actually, the idea of which started at the end of the Syrian refugee initiative, which was, if anyone can recall, was very chaotic in another major program that we went through. At the time, and in talking to colleagues across the country in both settlement and healthcare, it became very clear that we really have no idea what the existing care structures and care models are across the country, other than anecdotally when we talk to each other. We don't know what the differences are, and we certainly are not aware of readiness or preparation, or what are the adaptations that different jurisdictions do in order to prepare or to adapt for another surge. And at the time, just like Annalee, I remember the Syrian surge was this just really big event that the nation all came together. But since then, it's just been immediately on the heels of it, the Yazidi arrived, and immediately on the heels of that pandemic, and immediately on the heels, it's our constant. So preparation and adaptation is really key for health systems. And our hypothesis was not rocket science. We just thought that it would be a big hodgepodge with a lot of variation across our big country. So we conducted a prospective cohort study. Our goals were to understand those things that that I just mentioned. Our inclusion criteria were there targeted 55 jurisdictions. We initially started with more, but those 55 Canadian jurisdictions are the primary sites of resettlement across the entire country that have resettled at least 50 refugees from 2015 in 1 year, from 2015 till now. The data collection was launched, then paused due to the pandemic, and a special shout out to Nesma Al-Shazli, one of our teammates, who managed to survey the entire country, led harassed every one of you for an entire year to get the data that we were going to show you. In our study populations, we wanted to get data from the primary care clinics or the refugee clinics, public health, settlement offices, and then other specialized healthcare services that look after refugees. And we did surveys, we adapted WHO toolkit, and we framed everything to a WHO health system building block so that it could be agnostic, that it would fit into an international framework. We had 100 rounds of revisions again due to all the time and commitment from all our friends across the country. And so we got 64 primary care clinics that responded across 10 provinces and 37 of those jurisdictions. We got 106 registered resettlement agencies in 10 provinces and 1 territory across 63 out of 55 jurisdictions. So great job, settlement. Our major findings, and we'll show you the atlas, but the few really key important findings that we found is that our integration or coordination is poor. So when we asked across primary care, public health, and settlement, if they use pre-existing protocols or if pre-existing protocols exist to coordinate with other care providers, it was 20% for public health, 19% for settlement. And then when we asked our clinics if they had any direct communication with the Federal Ministry of Immigration as to the numbers and the dates of who to expect and the numbers of refugees that are arriving and who we would have to look after, that number again was very small, 14%. When we asked about preparation, only 40% of the clinics across the country had any kind of plans for preparation in terms of a surge. And then as we wrapped up data collection at the end of 2022, we asked if people were expecting to participate in the Afghan resettlement program. Most were, and about 62% of the clinics at the time felt that they were actually prepared to do so. And to me, this is one of the most shocking things that we found is we asked clinics to estimate the number of refugees and asylum claimants and patients that they look after each year. And we bounded a low case and a high case. When we multiplied that out over all of the 64 clinics and added them together, we calculated somewhere between 9,000 and 18,000 refugees and claimants and evacuees could be cared for with our existing structures. And then when we use the number from 2022, it's anywhere between 2.4% to 4.8% of the capacity we need to manage if we include the evacuees, or 5 to 10% if we exclude evacuees and are only looking at refugees and claimants, which is historically what we've done in the country, clearly showing a major capacity gap. In some of our other work, we've held consensus level workshops with settlement and healthcare providers last year at the North American Refugee Health Conference. And the only thing to show you here on the left is that when we asked across all multi-sectors, what were the main priorities that everyone wanted us to focus on to try to improve in refugee health? Navigation, coordination, better information, better care coordination across sectors, across health, settlement, and across government. And then we did the same with our patient advisory committee. We asked, we have an amazing group of people with lived experience in Calgary that help us. And they said, in their top 5 was we need help with navigation. And they also, a lot of comments around improved information and improved coordination. Lee?
And so this is where we get to the problem we're trying to solve. So this is exactly the problem we're trying to solve, is that lack of coordination between the immigration and health sectors, because this leads to barriers in healthcare access, barriers with navigation of the health and social systems, then inefficiencies within the health and resettlement sectors. And ultimately, why do we care is because that lack of access to healthcare leads to poor health and resettlement outcomes. Next slide. And so our proposed solution, and we understand it's only part of the solution, but what we can do as service providers is we could create this Canadian Refugee Health System Atlas. And what we'd like to do right now is to walk you through how it can be utilized And so the link is in the chat, so you can either click on that link if you're on your desktop, or if you have your phone, there's also a QR code on the screen where you can access the atlas. And so I'm going to ask Gabe to pull up the atlas. And what we're hoping is we'll give you a few examples of how it could be potentially utilized, but we would like your feedback on what is missing, how can it be improved, how can it be disseminated, for example, because we would like refugees themselves to be able to use the healthcare atlas, especially once we get it in multiple languages. But then how do we disseminate it so that it's in our newcomers' hands or on their phone? So all of your suggestions is what we're going to be looking for. So in terms of the atlas, it's there's a feedback tab at the top that you can see. And so certainly at any point, either today, but in the future, you can always click it and it will allow you to provide your input and feedback. And so the organization, there's 3 sections. The first part under the title organizations, this is really the navigation part of the atlas. And then below that, you have the health system organized according to the WHO building blocks. And then the last part of it are your hard data, so your immigration numbers. I don't know if you've ever had to give a presentation and you're trying to find the latest data in Canada, but it's difficult to locate, especially if you want to search by, specific provinces over specific timelines. And now with evacuees, it's in multiple different sites. And so we've brought all of that publicly available data, we've brought it into one location that's easily searchable and searchable for you, so it can meet your needs that way. So we'll go through each section one by one. So first, up into the organization section, you'll see there's a search tab. There's also the number of organizations relevant to your search. There's the map, and there's the bar graph that shows you whether it's a settlement organization, a primary care clinic, some other healthcare provider, or public health. And so one of the examples, we'll just go through different case scenarios to begin with. So what I was thinking is, if you are a private sponsor, so you're sponsoring a refugee family to be resettled as a privately sponsored refugee to Calgary. And you are searching out immigrant serving agencies that can help meet your new refugee family's resettlement needs. You can search Calgary. And then you can see that there are 4 organizations relevant to your search. If you wanted, and they're listed in a directory below the map, and then they're geocoded, so they're located on the map itself, and you can hover over each circle and you can get all the relevant information on that organization. You can go to the bar graph, and you can zero in on the particular service. So Gabe just highlighted primary care. So if the refugee family you resettled needed healthcare, you could click on primary care. It takes you to the one clinic that's dedicated to refugees. And then below in the directory, it'll list Mosaic Refugee Health Clinic with their phone number and a link to the website. And so you can just go to the website and find out additional information. And it's the same with resettlement organizations. So you could also highlight settlement organizations if that is what you were looking for. And you could hover over the organizations to get their additional detail, or go to the directory below and again click on the link, and there you go to CCIS, and then you'll have all the information on that organization at your fingertips. And then to reset, so there's a reset button. So once you're finished with that particular search and you want to search out something else, you just reset the button and you're ready to go. So another potential scenario that we run into quite frequently are transferees. So oftentimes refugees will be destined to one city. I might start seeing them at the Mosaic Refugee Health Clinic for their pregnancy, for example, and then they decide they're going to move to Toronto to be with family, or they've heard there's better opportunities, there's much more of a community in Toronto. For some reason, they decide to move to Toronto. And you as the healthcare provider, you might be wondering, where could they potentially get healthcare in Toronto? And so you can search Toronto, and then you could highlight primary care, and then it'll show you the different primary care clinics in Toronto. And so you can search those different primary care clinics, and you could potentially find the one that is closest to where they might be living. You can hover over it. It'll tell you exactly what it is. And then you can click on their link and then get all the relevant information. And you could share that information with your patient, and you can potentially call and book an appointment with the refugee when they're there with you, and book their first appointment. So it's very helpful in terms of continuity of care and helping people access services when they move to a different jurisdiction. Other potential scenarios would be if you had, let's say, for example, if one of my Yazidi refugee patients, and many of the Yazidi, let's say I had a Yazidi patient who suffered from PTSD and they decided to move to Vancouver, I can search Vancouver. And then it shows there's 6 organizations relevant to the search. And so I could look at each of those and see what sort of services they offer, and do any of those organizations offer mental health services. So I can also go to other, and then if I hover over those dots, I see, oh, it's a survivors of torture program, and I can click on the link and have a better understanding of what services they could potentially provide. And then I can connect my patient moving to Vancouver who is in need of trauma counseling to that particular resource. And then you can reset it. And so those are just a couple of ways you could potentially use it. So if you're a service provider and you're looking for resources, if you're a refugee yourself and you're looking for resources, you can use this navigation tool to connect your refugee client or patient to the appropriate resource. And now we'll move on to the WHO building blocks, and I'll hand it over to Gabe to review this section of the atlas.
Perfect, thanks. So it doesn't super helpful at a navigation function. It doesn't really help those at a health policy, planning, management level, or when you're trying to actually prepare. So thinking more at the level of a clinic, all the way from a clinic manager or a medical director at a clinic, all the way up to, Federal Ministry of Immigration. It's hard to know what our system looks like. And so we took the data from over 200. So we asked for levels of consent. So those that consented to be put on the map were on the map, but everyone else, we compiled the data to put together an actual overview of what the system looks like in Canada. So I'll just walk you through some of them. And again, it's all interactive. We ask, how long these clinics have been in operation. And you can see here that over 72% of the clinics have been in operation for more than 10 years. This was in 2021 when we finished data collection, end of 2021. But you can see that there are some that have are relatively new. And then you could, click on your province to find out, well, what about my province? Well, Nova Scotia has one, and it's somewhere between 5 and 9 years it's been in operations. The other thing here is this kaleidoscope of colors. We basically ask, well, how often or how long are refugees and cure patients, migrants cared for at your clinic? And again, you see this just massive variation. And if I look at Quebec, for example, you can see that the majority of their clinics are, less than 6 months. So their patients are seen for a short period of time and then transitioned out. Whereas where we live in Alberta, the majority are between 1 and 2 years. And in Ontario, you have a much greater proportion of folks that hang on to their patients for longer than 2 years. So you can see this just immediately just shows you that the variation of, oh shoot, I did the one thing I wasn't supposed to do. There's a glitch that our software engineer made me promise not to touch, which was that. Okay, so then we can ask questions about, well, who do you serve here, or how are what are the types of clinics we have? But more importantly, and there's a few that everyone is very interested in our day-to-day work. So oftentimes our clinics are, as a lot of healthcare, and especially in primary care, as we know, is underfunded. So trying to understand how are these clinics funded and what is the method in which they stay open. And so we asked a couple of questions, and what is the main mode of remuneration for physicians? And here again, you can see this grand variation. Most are either salaried or come from something called other, which I think are the alternative remuneration plans and so on. But there are still a hodgepodge of those that are fee for service. And again, this just changes dramatically depending on which province you're in. So you can, we looked at Saskatchewan earlier, where they have 100% salaried or remuneration, and other provinces have different. We then ask, how do the clinics have operating costs? What are the operating costs managed through? And it's often through institutional budgets, budgets that come from operational budgets from family medicine groups or primary care networks, et cetera. But 10% are living off of fee-for-service fees, which is much lower than the average in Canada, but still, again, a variation across the country that you can look at if that's of interest. Also, we never know who, until we finish this study, we actually never knew who worked and what was the staff or the workforce. So there was no actual understanding of we've been asked 100 times, what makes a refugee clinic? Like, what do you need? What's the recipe? And so we boiled down, and this is again high level, but we have much more detailed information. We took data around the number of physicians and workforce in the clinics, and then we boiled it down, or we normalized it to a full-time equivalent. So in red is the national average. So on average, these clinics that have self-identified as those that care for refugees, claimants, and evacuees have on average about a 2.81 FTE equivalent of family physicians in their clinic. But again, a huge variation. In Manitoba, New Brunswick, it's 1, and in Saskatchewan, it's 4. And then same thing when we ask about nurses, the 3 types of nurses: licensed practical nurses, NPs, or registered nurses. Again, a major variation. On the national average, it shows you both. So the national average is about 3 per clinic. and then just over 2 nurse practitioners and LPNs. But in Saskatchewan, you can see there's a much higher proportion of nurses, whereas in Quebec, a bit lower. And then again, where we live in Alberta, somewhere in between. But we certainly have a lot. Nurse practitioners, for example, there's a broad variation. We also then asked about the multidisciplinary team. And so here's all the different potential multidisciplinary team members that exist in these clinics. And you could see across the country, the most common or the most important are social worker, physiotherapists, licensed LPNs, occupational therapists, and dietitians. But there's a broad variation. And then if you're a care provider and you want to know, well, what do refugee clinics actually do? We summarized some of the major health service delivery function of a refugee clinic based on the clinical guidelines in Canada, both the Canadian and then internationally. And you can see a lot of infectious disease screening, despite that broad variation in structure and who works at these clinics. You could see the care functions. There's a lot more uniformity. So hepatitis B, Hep C, HIV, and TB screening, and enteric parasites is pretty standardized across the country. Malaria, less so. And then interestingly, management, so TB management, parasites, enteric parasites, the grand majority of provinces are doing it in-house. But then you get to HIV, hepatitis C, and malaria, and you can see there is this variation. In New Brunswick, everything gets handled in-house. In Quebec, less so. We also asked about immunizations, which since COVID, we all know it's really important and a major cornerstone of migration health for newcomers. A lot of the clinics are providing the immunizations in-house, but not where we live in Alberta, for example. And then we asked about interpretation and translation services, and here's this wide variation of different services that get used for translation. And I'll just show you, I think there was one more thing, but I could just stop for time so we can get to the immigration. Oh, preparation, which I already showed you in the other slide. So I'll hand it back to Lee.
And so the final part of the atlas is just compiling all of the hard data from various publicly available data sites into one spot. So looking at all refugees, so all categories. So looking at government-sponsored, privately sponsored, Blenda Visa Office referrals, asylum seekers or refugee claimants, plus now since 2022, the evacuees who are all from Ukraine. And so you can look at, there's the map, so you can look at the map of Canada and you understand from just looking at this map that Quebec and Ontario, for example, have huge numbers of refugee claimants as a proportion of the newcomer population or refugee population coming to those provinces, where it's much less so in the prairie provinces. And that only makes sense. You also, sorry.
Good, you're good.
Yeah, sorry. Yeah, I got a phone call and I went offline there for a sec. So you also have the top, you have the ability to manipulate your time frame. So for example, if you're only interested at looking at the number of refugees coming since the end of the pandemic, so let's call that August 2021, when we started to resettle the Afghans, you can abbreviate the time frame, or you can specify the time frame that you're interested in, and then it would give you all of that data, including at the top the total number of refugees. Then you have the pie chart across the nation, you have the bar chart, and then you have the ability to filter. So you can filter by province, by category of refugee and evacuee. And so, for example, if let's say you're just interested in your own province, you can tick Ontario and you can choose your time frame and you can understand immediately what the numbers are arriving in your province. Mm-hmm. And you might be interested in just looking at, for example, asylum seekers. So you can look at Ontario and you can click refugee or asylum claimants and very quickly understand the numbers.
Mhm.
And so this not only helps you in advocacy, but it also helps, hopefully helps policymakers in terms of planning. Because if you're like Ontario and Quebec, where a large proportion are asylum seekers, the complement of services might be very different than if the majority of your refugees coming to your province or city are government-sponsored refugees.
Mhm.
And so this just shows how you can filter by the different categories of refugees. And, you know, the way the government, you know, how IRCC, you know, there's an administrative sort of jurisdiction. So for example, if you're talking about the PNT region, which is Prairies, Northwest Territories, and Nunavut, you could select or filter based on the PNT region by selecting those provinces, and then have a very good idea in terms of the number of refugees arriving in that region.
Mhm. Mhm.
And so I welcome everybody to play with this and, you know, use it. I know I've been using it. It's been very helpful for me, for example, in preparing presentations and talks, to have everything located in one place.
So just two quick things to show you. Click on this button. It will take you to a single question. Please give us any feedback. We promise you that we will answer, and we will update this thing in real time as quickly as we can. The other one, which we'll show you after, is to join or update the Atlas, which is our second big request of the user community across country, and to please disseminate this out to your friends, your network. We know that there are agencies that did not, despite our best ability, you know, our best attempts at trying to survey everyone in the country. We know that there's organizations that are not on the Atlas currently. So if they just click on this button, it'll take you to updated standardized surveys to get people included. Whoops. We also know that if you were already in the Atlas, we know things change. We know things change very quickly, as we showed you that it's constant chaos and there's a lot of adaptation. So we really want those that are already in the Atlas to provide an update. And our hope is to do every 2 years to put out an updated, fresh Atlas with a brand new set. Also in this update survey, we have for those that there have not been a lot of changes, we do want as many people in the community, user community, settlement, healthcare policy, to answer these surveys if they can, because there's a lot of, we've added a very short section of questions asking around, well, what are your biggest challenges? What are your proposed solutions? What are the innovations that you think can be scaled across the country to try to solve problems that we're seeing together? And also we asked some questions around, help us prioritize. What do you think are the biggest priorities, as we showed you before? So we encourage everyone to please, take 15 minutes and do these surveys and add and help us build this thing out. So I'm just going to stop and then pull back up. We're doing well for time, so I'll just pull back up the end of our presentation. And then we've got lots of time, hopefully, for...
Yeah, and we already have a question, and so we'll get to that shortly. And
Yeah.
so I guess the last thing we want to say is Gabe and I were invited by the WHO to present this in the fall, and they're interested in scaling this up globally, which we're thrilled to participate in, but we really want to perfect the Atlas for Canada first before scaling it. And again, this is why we need your help in perfecting this Atlas.
And this is what happens when you let your friend choose the picture. This is I was like, find a picture of us in Geneva, and this is the one she chooses. But then also like a specific shout out to the Health and Migration Program or department now at the WHO we've been working out with. They are fantastic. It is an incredible resource. They have an entire group of people across the world that do exactly this work. We're very excited to be working with them. And highly recommend that if you haven't or you knew nothing about this program to go, because they have a ton of great resources for everyone. Okay, that's it. We made it and we finished early, so we can stop sharing. Oh, wait, we didn't. So close.
Yeah. We're almost done. So, to state the obvious, there's poor coordination between immigration and health sectors, and this is leading to a mismatch between the needs of refugees and the availability or access to health services. And this poor coordination and the lack of information sharing between the federal and provincial governments, and indeed even across provinces, leads to health systems that aren't prepared to meet the needs of newly arrived refugees, and in particular when we have a surge. And the Atlas is designed to fill the coordination and navigation gaps by providing relevant information for patients, also for service providers, and hopefully for policymakers. And then the ongoing development and perfecting of the Atlas really requires engagement from everyone, all stakeholders involved in refugee health and resettlement and settlement. And so we're hoping that you can provide us advice today and in the future on how we can improve the Atlas utility and usability for healthcare and settlement providers, how we can improve beyond just embedding the multi-language function, which is next on our list, but how we can improve it beyond that to make it useful to newly arrived refugees and asylum seekers and evacuees. And how we can disseminate it for use beyond refugee service providers, because I feel like we're the people who are in the know, but how do we get it into the hands of people who might not know how to find resources for refugees?
The emergency department.
Yeah, in the emergency department. And how can we make the Atlas sustainable? Because this is currently funded by research grants, which don't last forever. So how do we make this sustainable moving forward? Gabe?
Okay. Yeah, first I have to thank the Refugee Health YYC team and Center for Health Informatics team, Rabina, Eric, Vaughn, Rob. We almost killed them in the last 2 weeks with this. This was a complete rebuild of the Atlas. And so they all are fantastic. We couldn't have done it without their team. And then we just, an acknowledgement to Paul Farmer, who I was fortunate enough to get to do some training under. He died, unfortunately, last year, and he was such a giant in our field. But, this quote is very apt for what we're hoping for is, in Canada, it's very un-Canadian to say it, but like we are really good at this. And it's this really exciting thing that we started this work just in our own little country. And there's this opportunity for us to take it global. And so that only happens if we do it together and working in partnership. So we're very excited to take notes and work to continue to make it better. That's it.
Thank you. I see we already have some questions.
Absolutely. We have questions rolling in, but first, a big thank you to Annalee and Gabe. Thank you so much with sharing the work that's being done for Atlas, and we look forward to hearing more as things develop. We do have some questions from the audience, so we'll dive into those. And please keep those questions coming. We have Gabe and Annalee, and they're here to answer your questions. Any questions that we don't have an opportunity to get to today, we will take offline. So we'll make sure that that happens and your questions do not go unanswered. So with that, obviously praise to you both and the work of your teams. Great work, and thanks so much. They see a lot of work going on behind the scenes. The question is, I presume these numbers in the Atlas are official statistics. How often are these numbers and information updated?
Oh, I got this one. Let me just show you. I don't know if I'm muted. No?
You're good, Gabe. And we have a visual.
Right here. Hit this button. Here are your sources. These are, if you just click on it, these are IRCC. It's publicly available data across multiple different branches and sites. So the evacuee data comes from Ukrainian Safe Haven. They have a data platform. And the rest comes from the government of Canada under different data platforms. So if you go here are the asylum data, and they get updated monthly. So, we truncated at January 2024, but it's updated up to March. And so our plan is to make sure that we, pull in these data as often as possible to keep it at least updated up to within 3 months. But if you are interested in finding these data yourselves, just go to the info and all the references are there.
But ultimately, I think like our goal, what we would really like is for AI to sort of help us automatically populate this tool.
Yes.
That would be sort of the most accurate way to ensure that it's up to date regularly.
And IRCC they were really instrumental in getting us started. They're our knowledge user. And so one of the hopes we have is just in our sustainability is, can we get direct access to the data in an API form, in a form where it can just get automatically updated with AI. And then this can be the place where all those different subcategories get updated. The other piece of it is to have it updated right to the jurisdiction level. So we haven't done it, but like by next week, if the team doesn't kill us, we have data at the jurisdiction level. So for the 55 cities or 65 cities across the country, it only contains evacuee and refugee data, not claimant data, but it's still super useful if you want to know what's going on in your specific city.
Excellent. Thank you so much. Were there any priorities or gaps in your research that individuals brought forward that surprised you? That you didn't see coming?
Yeah, I mean, I would just, what surprised me the most, and this was from our health policy workshop from last year. I was surprised at how well everyone got along. There was a lot of nervousness to start with. Government, American, like the CDC, the US government, Canadian government, healthcare providers, settlement. We had not shy refugee community leaders and, some advocates in the room. And so the thing that surprised me the most, this is me personally, is that when we ran through this 2-day workshop where, it was pretty structured exercise to try to come up with priorities, how ubiquitous the priorities were and how they actually are very shared, and how easily people identified things like we need to improve our coordination, our communication, and our cooperation between these jurisdictions. And then just how we also asked, like, prioritize, give us the priorities, but tell us which ones to do first, which ones are the most actionable. And again, I was surprised at just how quickly and how well consensus was achieved. It gave me a lot of, I think it's a very Canadian thing that we could sit in a room together and work it out. But it actually gave me a lot of hope that there are solutions. And so, this is just one offering, but there are many other things that I think we need to work on.
And I would say, like, I'm surprised that this is an ongoing problem, that there's still not, like, with all of the technology that we have, with all of the great people involved in the federal government, provincial government, the health systems across Canada, how we still have this gap, how it is that the government chooses to bring the most vulnerable refugees, meaning women and children at risk, survivors of torture, those with high medical needs, yet there's no seamless entry into the health system upon their arrival. That it's not part of the bucket of services we routinely provide newly arrived refugees anyway. Like, so that's still shocking to me.
Thank you so much, both. That pre-arrival key. Can we add services in our area that we are not directly affiliated with, but are known to provide settlement support?
Yeah, so I would say you can be very helpful, but when we originally made the surveys, they were directed to make it most efficient. The surveys are and the data collection is it is designed to go to someone who can speak for their organization. So a manager, a clinic director, a medical director, or their delegate. Again, that last section of questions can be by anyone in the community to tell us what are your priorities, what are your challenges, what are your innovations and ideas. That is for everyone. But if you have colleagues or you know of organizations, like the best thing you can do, as in everything, is just tell your friends. You know, in our world, in the healthcare world, if there is a cool new tool or innovation or trial or drug, we all just share it among our friends and our networks, and that's how it spreads. And truly, that's the best way that these sorts of things spread. So if you think it's useful and you know that there are, because we know it was our first pass and we know that we're missing people, but if you know that there's organizations in your community and you know you have contacts there, please just forward it on, ask them to join. It's, you know, it's a 20 to 30-minute survey, depending on how much detail you want to give, but it's super helpful for everyone else.
Yeah, and so if you're an organization that provides services, whether it's in the resettlement or health sphere, to refugees, even though it might not be dedicated towards refugees, but if they do serve refugees, then you're welcome to, then that organization is welcome to join our platform. They might fall under our other category, and that's totally fine, but we want to bring all organizations that serve refugees onto the platform, into the tool.
Thank you both. Has there been any conversation with immigration officials to make IFHP more user-friendly for service providers enrollment, given the growing numbers of refugee and asylum seekers?
From my conversations with IRCC, they have been working on it. Like, I feel like with IFH, IRCC did hire somebody to be that liaison between settlement and health. And she's been advocating with the leaders of IFH to make it more user friendly. And so, as you know, things move slowly. And I know that, I've been around for 14 years and it's always been a conversation. I do see things improving slowly over time. But I think more recently, there's like probably since 2021, there's really been an effort for IFH to be more user friendly. And in fact, with our Canadian Refugee Health Network, which is health providers from across Canada, like IFH has even come and presented at some of our meetings. And so I see that they're engaged and they're receptive to feedback. And I think they're trying to make change, positive change.
Excellent, thank you. I'm just scanning to see how much time we have left. I think we have time for one more question. That went by really quickly. The latest call for proposal for IRCC funding from 2025 to 2030 included the role of well-being navigators. Health navigators for those with complex health needs, were refugee providers involved to date in the role of that design? Are you aware of if the refugee providers were involved in that work and that redesign?
A little bit. Like, this is again, like this is that liaison between health and resettlement that IRCC, it's a role that was new to IRCC, and she has been very effective at liaising with health providers, getting provider feedback, and in the development of that role. And she's a nurse by training. And so she's a healthcare provider herself. So she's been the one who has really advocated for the health navigator role within the resettlement sector. So I would say we were consulted. I mean, I wouldn't say health providers were into the nitty-gritty details, but we were definitely consulted.
Thank you so much, Annalee. And it looks like we are now at time. I thank you both so much for this opportunity to connect and share Atlas's work. I'm just going to put up our closing slides. So thank you again. We hope that the audience will be able to join us for future webinars, and we'll be sending things that were unanswered back to Gabe and Annalee to be answered. So thank you so much. And maybe I'll give you a moment to say your last few words, then I'll launch into our closing slides.
Just thank you, everybody. I'm seeing some really good suggestions in the chat box. So I really appreciate your feedback. And I think you've actually given us some really good ideas in terms of including other vulnerable newcomers as well, and the legal supports for asylum seekers. So great ideas. And yeah, this is how we're going to grow and perfect the tool. So I really appreciate your help. Thank you.
Thank you, Annalee. And over to you, Gabe.
The same. We make corny jokes about being Canadian all the time now when we're at these international conferences and stuff. And so I think as good Canadians, we end with gratitude and an apology, and we'll end with the same. So I'm sorry about the slides and not having a perfect tool. And we are very thankful and grateful to everyone in the country. Honestly, it is like the least Canadian thing to do, but it's, you know, since December, since Annalee and I've been working with the WHO and UNHCR, it's just this, like, it is really, been this amazing realization that we're really good at this, despite all of the things that we need to make better. And it's really nice to represent our country doing something like this. Humanitarian work and improving healthcare for people that need it, and it's something that personally we're super proud of. And so that only happens because of this community, and a tool like this doesn't get built by, you know, even 4 people. It was hundreds of people that took the time to do it. So that's it, just something that we can be proud of. Some good news for once, maybe.
Thank you so much, Gabe. And For's very proud to have been a part of this, and we'll be sending those questions your way. So I'll just launch into our last minute slides. Audience, if you missed any part of today's presentation or you'd like to watch the session again, we will post the recording on the N4 platform within the next week. We want to continue the dialogue this presentation has started. We'll be moving all questions we did not get a chance to our N4 platform. We also have several resources, so please be sure to check those out. If you're not a member of N4, please do sign up. Following today's session, we will be asking you to complete a survey. Please take time to do that. And some of our upcoming webinars are currently listed on your screen, so we hope to see you there. The ITP and IAN pathway was published in December by N4. We are very proud to highlight these products, which are now part of N4's IHP Resource Hub, and be sure to check those out. We're now focusing a communication strategy to get this out to IENs via their formal and informal support groups and the settlement and healthcare employers. Check out our N4 mobile app if you have not already. You can go to Apple Android devices through the QR code here, or by going to newcomernavigation.ca/iOS or Android. Thank you again. Big thank you to Gabe and Annalee, and we hope that you'll join us at future N4 events. Stay well.
Thanks, Colleen.
Thank you.
Yeah,
Thank you guys.
You. I mean, it's all about navigation, so I feel like we're very well aligned.
Connected. Here. Yes, exactly. I will see you both soon.
Okay. See you.
Cheers.
Bye.